Odontogenic infections are a common presentation. They refer to infection caused by teeth. They need definitive treatment, for example drainage of the abscess or removal of the tooth or dental pulp. Bacteria are the cause of odontogenic infections, and they commonly arise from a necrotic pulp, periodontal pockets or pericoronitis. Do not trivialize odontogenic infection. If not treated properly, they can compromise the airway or cause overwhelming sepsis. The way they present represents a wide spectrum. They range from small localized swellings to Ludwig's angina. Control of infection in the head and neck can be unpredictable, and infection can spread via the tissue spaces to involve the cavernous sinus and the mediastinum. These are some of the tissue spaces that can be involved with an infection from a lower molar tooth. Familiarize yourself with them, as these infections are common and you will need to be descriptive when documenting your findings and communicating them to your colleagues. Signs and symptoms vary enormously. Swelling and suppuration are commonly seen, but fistula formation tends to represent a more chronic infection. Pyrexia and cellulitis may be seen in some infections. Remember that a significant abscess caused by an odontogenic infection may not have been preceded by a toothache. Your examination must be thorough. Look for dental caries, decoronated teeth, teeth with large restorations, and seemingly edentulous jaws that may possess buried roots. Advanced periodontal disease, dental caries, and pericoronitis are common causes of cervicofacial abscess, but they are not always as obvious as these pictures. Periradicular or periapical pathology seen on dental x-rays may give you an indication as to the source of the infection. Remember that with an acute abscess, periapical changes are not always seen, so be suspicious of carious or heavily restored teeth. These features are signs of more severe infection. If the patient is unable to swallow their own saliva, or the floor of the mouth is raised, then you should be thinking about getting the patient prepped for theatre, as they will probably need urgent incision and drainage. Stridor is a sign of impending airway obstruction and should be taken very seriously. Tachycardia and tachypnea are signs that the patient may be going into shock and will need some resuscitation. Pyrexia is common in the odontogenic infection, but should not be trivialized. On the most severe end of the scale is Ludwig's angina. This is a spreading bilateral cellulitis of the submandibular and sublingual spaces. This patient's floor of mouth was raised and his tongue was swollen. Edema can progress to airway obstruction, which is why this is a surgical emergency. If a case like this presents to you, then you should inform your second on-call immediately and make arrangements for transfer to the operating theatre. Here is a list of some other infections you are likely to encounter. Remember that odontogenic infection is the commonest cause of abscess, but you shouldn't assume it is the cause in every case. You should read about the conditions listed here and familiarise yourself with them and their treatment. Skin infections come in many forms, but the most common is cellulitis, which is usually caused by a staphylococcal organism. Staph also causes boils, folliculitis and impetigo. The culprit in erysipelas is often a streptococcus. Primary skin infections differ from odontogenic infections because they start superficially and may originate from a breach in the skin, for example eczema, acne, an insect bite or a skin wound. Here are some presentations that you might see. Note that necrotizing fasciitis, although rare, is an emergency. The infection cannot be dealt with by antibiotics alone and needs surgical debridement of the affected tissue. These are some of your options for treatment. If you can see a collection of pus that can be drained under local anaesthetic, then get on with this and don't just discharge your patient with oral antibiotics. If this cannot be achieved, then admit the patient, commence intravenous antibiotics, keep them nil by mouth, and schedule them for theatre. Small abscesses are easily drained, and you can also insert a drain or extract an offending tooth under local anaesthetic. Instructing the patient to use copious hot soap mouthwashes after drainage is a good idea, as it keeps an incision patent and draws out the pus. Extraction will not always be desired by the patient if a tooth is restorable, and in this situation you can ask for the assistance of the dental hospital if one is affiliated with your unit. This is a typical dental abscess caused by an upper right 3 with a large restoration and a necrotic pulp. This is technically very easy to drain. Local anaesthetic should be injected away from the collection of pus because you do risk spreading the infection if you inject straight into the abscess. The diagrams show how simple incisions can be made to drain abscesses. Long incisions are better than short ones, as short ones tend to close up relatively quickly. Criteria for admission includes considerable fever, signs of dehydration, and anyone in whom local anaesthetic will not be possible. Patients who have diabetes or take immunosuppressants should have any infection treated aggressively. If you decide that admission is appropriate, then make sure you request and follow up these investigations. An OPG is necessary even if you think that infection is not odontogenic in nature. Blood tests including full blood count, urea and electrolytes, and C-reactive protein should be taken. Also, take laboratory glucose for anyone admitted with an infection, as infection is sometimes a presenting feature of a previously undiagnosed diabetes. Commence intravenous antibiotics, and if the patient requires treatment under general anaesthetic, then keep them nil by mouth. These are the usual treatment regimens for infection, although it does differ from unit to unit. If the origin of infection is the skin, then you'll need to cover Staphylococcus. Flucloxacillin and benzyl penicillin are usually sufficient. Consent the patient for the appropriate operation and book them onto the acute theatre list. Patients with infection require regular review to ensure they are responding to treatment and not deteriorating. This is a typical consent form. Make sure the patient is consented for incision and drainage of the abscess and extraction of necessary teeth. If the patient has a neglected dentition, then they may well need several teeth removing or even a dental clearance. It is important to warn the patient that extraoral incisions for drainage can scar and may need revision at a later date. Sometimes a rather nasty infection will require several trips to the operating theatre to control it, and the patient should be warned of this. The typical neck incision for an extraoral drainage does risk damage to the marginal mandibular nerve, and the effects of this should be included on the consent form. In summary, you must identify the source of infection, the structures that are affected and its severity. Remember that the patient may be systemically unwell. If amenable to local anaesthetic, do perform local treatment and provide antibiotics. You must have a good knowledge of the signs of a severe infection and escalate any concern to your second on call.